Good morning, everyone. My name is Carla Bartholomew, and I'm with Clinical Public Health here at GWSMHS. Welcome to our third Clinical Public Health Learning Lab, the Community Responses to COVID-19, Addressing the Needs of Marginalized Populations. We began the Learning Lab educational series in March to explore the pressing clinical public health issues and have conducted several since then related to COVID-19. Our panel discussion today builds on our most recent Learning Lab, in which we highlighted the disproportionate impact of COVID-19 on marginalized populations. And to moderate our panel discussion, we're joined by Dr. Lisa Fitzpatrick, an infectious disease physician whose career has spanned research, clinical medicine, community health, and patient advocacy. She's worked at the CDC, recently served as a medical director for the Medicaid program here in DC, and is clinical professor at GW School of Medicine and Health Sciences and a professorial lecturer at Milken Institute School of Public Health. Dr. Fitzpatrick is also founder and CEO of Grapevine Health, an organization dedicated to improving health literacy and patient engagement here in Washington, D.C. Welcome, Dr. Fitzpatrick and panelists. Thank you so much.
Thank you so much, Carla. I really appreciate this opportunity to have students, faculty, and whoever else is listening hear from some of our community leaders. So I think this will be a really exciting and insightful conversation. We are still waiting on a panelist to join us, Miss Dion Bussey-Reeder, so hopefully she'll join us. I think she's having some technical difficulties. But in the meantime, let's get started with Christy Respris and Kim Ford. And I'll be a little non-traditional in having you introduce yourself, because I would like for you to talk to people a little bit about things you've learned during the pandemic. So we'll start with, so it looks like Dion has joined us. Dion, can you hear us? You're on mute.
I can't hear you. Can you hear me?
Yes, great. Okay, we were just getting started with introduction. So welcome to the conversation.
Thank you so very much for having me. My sincere apologies for joining late.
Yeah, I can see you're in your car, so I appreciate you squeezing us in.
Little schedule conflict, but we're good.
Okay. So Christy Respris is the Executive Director for Pathways to Housing DC. And for each of you, I would like for you to take 1 minute to introduce your organization, tell people what you do. But also, if you could take a couple of minutes to tell a story from the pandemic that helps people understand the impact of your organization, maybe something you learned during the pandemic that you think would be helpful for folks working in the health sector.
Okay, no pressure. All right. So thanks for the introduction. And again, I'm Christy Respris. I'm the Executive Director at Pathways to Housing DC. And at Pathways, our mission is to end chronic homelessness for people living with serious mental illness and other chronic health conditions, substance use, physical health challenges, using the housing first model. We were founded on the belief that housing is a basic human right, and that in order to solve really complex social and health issues, we need to listen to the people that we serve, because they will tell us the answers. That is why Housing First was born. So kind of just very quickly, our programs, we serve about 3,500 people a year in the district and newly in Montgomery County. Our kind of premier, what we're known for most, is our Housing First program. We have 635 people living in their own apartments with their own leases, who are all experiencing long-term homelessness in all 8 wards of the city. We also provide really intensive wraparound health services to support people in housing. And then our front door services include street homeless outreach, where we cover geographically downtown DC. We run also a behavioral health clinic in the DC Superior Court, and partner on the Downtown Day Services Center, which is a one-stop center to end homelessness located at New York Avenue Presbyterian Church. But ultimately, all of our services have one goal, which is to end long-term homelessness and put the person at the center of that decision making. So many lessons learned on COVID. It's I think And I was thinking you had asked about kind of storytelling and lessons learned through there. I think for us, we were reminded from day one, and you had written about this, Dr. Fitzpatrick, an article about us not being all in this boat together. It's very clear to us that people who have housing and resources versus people who are experiencing homelessness, or even people who have housing and have no resources, have very different access for basic needs such as food, shelter, healthcare. These are not surprising, but it's very clear. And one of the big lessons learned, and I say there's so many, but I share this because of who this panel is addressing, is really the systems that we can make dramatic systems change very quickly when motivated and when empowered. And what I mean by that is I think about all the no's we got for many years on ways to provide healthcare services to people experiencing homelessness. So I'm thinking of one of the people that we serve, our outreach team was working with, who's living on the street, HIV positive, living with some serious mental health challenges. And those concerns, it's hard enough to deal with those things on the street, and then you add COVID on top of it. We saw very quickly that people who, for whom we were working with, that COVID, all the advice and all the information coming out day one around social distancing, hand washing, stay home, were things that none of the people that we serve on the street could do, right? So our staff actually said, how am I handing out this flyer when our folks can't do any of these things? Like this is just atrocious. So to address some of those things, we of course gave a lot of information to people. Like health information was like one of the first things we had to do. Getting out there, dispelling rumors, making sure people had masks and had hand sanitizer and had hand washing stations, et cetera. But on the lessons learned side was that, we knew that we needed to get people very quickly into housing situations. And while there was not enough access to housing, we were able to work with the city to open several hotels for people who were at risk of contracting COVID. So they're not just for people who are COVID positive, but really using the public, the health data that we have already on hand to identify people who are most likely to contract and die of COVID because of underlying health conditions and age. Those kinds of things prior to the pandemic didn't happen very quickly. It would take months and years to do a program like that. But because the urgency, because we had partners who got it at the city level, federal, but mostly the city level, we were able to partner to get that up and running, redeploy staff to work in the PEP-V hotels, identify on the street people like Michael, who was, on the street, again, HIV positive, over 55. We were worried if he got COVID, he would pass away. So the ability to move him into a temporary housing situation, which ultimately now is turning into a permanent housing situation, shows us that if we put the right resources and the right energy to systems change, we can do it. And I will go on and on. I could go on about telehealth, and we'll talk about that maybe later. But again, rules that we thought we couldn't do things, we can with the right push and the right collaboration. I'll stop there because I could go on for a long time.
Thank you, Christy. We will talk about telehealth in a little bit. I think for this audience, that's a critical topic. But before I move on to Kim Ford, I just wanted to remind people who've just joined us, we're having a great conversation with some of our community leaders who've been very active during the pandemic. And if you have questions, please put them in the chat, because we will allow 15 or 20 minutes at the end to entertain your questions. So, Christy, I think the comments you made about being able to demonstrate our ability to scale up if the will is there is a great segue to Kim Ford at Martha's Table. Kim Ford is the president and CEO of Martha's Table, and you have been such a force during the pandemic in providing the food and nutrition needs of the community. So I'm very interested to hear the story you'll share and help people understand the impact. But the first thing before you do that, I want to let people know that I take notice at the food that's being delivered by different organizations. And when we do outreach, I've participated in outreach events with dozens of organizations. And the food you all give out is consistently high in nutritional value. And I just want to say thank you for that. You don't give out Oreos and Pepsi. So thank you so much. Maybe you can also tell us a little bit about why you've made that decision, because I think it is a conscious decision. But tell us about you and the story you want to share about your impact or something that touched you.
Absolutely. Thank you so much, Dr. Fitzpatrick, for inviting us and having us, and for GW and the Learning Lab. So happy to be here. Here at the Great Martha's Table, we are 40 years old and 40 years strong. And, you know, a little bit about Martha's Table. In these 40 years, we have evolved from what folks would have called a soup kitchen into our free food truck, a McKenna's wagon that goes out every day, no matter weather, no matter holiday, no matter global pandemic. We have evolved from what folks would have called a food pantry into healthy markets, lobby markets in Southeast and in Northwest, and 53 joyful food markets that pop up in every elementary school in Ward 7 and 8. And to Dr. Fitzpatrick's point, always with fresh fruits, fresh vegetables, and healthy shelf life items. We've evolved from what folks would have called a thrift shop into our Outfitters boutique, where people can shop at no cost for children's attire, children's clothes, and adult workforce attire. And we've evolved from what folks would have called a daycare into nationally accredited early childhood education centers in Southeast and in Northwest. COVID landed on us on 5 days after the first person was diagnosed in DC with COVID. We turned our operations on a dime. And so we put our nationally accredited early childhood education centers on hiatus and went into a virtual learning model. And we knew that we had to continue with our food distribution. Our joyful food markets were shuttered because the schools closed, but we went and supported all of the DCPS meal sites in Ward 7 and 8. Our lobby markets, both in Southeast and Northwest, have not stopped. And we actually launched additional community pop-up markets in Southeast for those who might not be able to get to us for transportation, safety reasons, other reasons. And so when a number of folks started to close, we actually expanded. And then the story that I'm going to share actually isn't food related. I know we'll probably have a lot of conversations about that. But when we closed our schools or sent our young learners into a virtual environment, we knew and accurately, though unfortunately, predicted that our families were going to get hit so hard by this, right? We felt it in our guts. Remember, this is 5 days after the first case. And what we did was we provided a comprehensive package to our families, 137 families representing 207 young people. And what we did was actually give cash, free and clear, to our families, plus $15 a day worth of grocery gift cards, plus diapers, wipes, and formula. And the story I want to share is Miss Dennis. So Miss Dennis is one of our parents. Her little guy is 3, and she owns her own salon. The salon went under. She wasn't eligible or wasn't able to get unemployment. She is very well aware of health concerns, as her oldest son actually had a terrible case of the flu a few years ago and spent 2 months on life support. And Miss Dennis's entire life started coming down and almost having, like, you know, the reaction of, oh my goodness, here we go again. And what she said to us was that the cash transfers helped her stay afloat. She didn't know what she was going to do without the money. We did this for 4 months. It was $9,000 for each family. And, you know, I have quote after quote from her around, like, this was a godsend, and this has been such a help for our family. But more than that, she said that it just made her want to get more and more involved. And she's from DC, and she said it just made her want to get more involved. She's now an advisor on our strategic planning committee. She's a leader on our parent council, and she volunteers. And one of the things that we have seen over and over and over again are people who come to us for supports such as for food, they say, well, I don't have any money right now, but I'll donate, so you have clothes for the boutique, or I'm going to come and I'm going to volunteer. And Miss Dennis just completely embodies that. I saw her the other day and she was just saying, she said, Martha's Table is like a family, and family sticks together and family stands with each other. And you guys were there for me. And we always say, no, you're there for us. And so what COVID has shown us at Martha's Table is that people are bonding together. The times have been tough. I mean, obviously, COVID, racial injustice, mass unemployment, all of this is terrible. But the things that it wasn't like things were good. Our colleague Christy talked about, some folks that was good, and now this is the annoyance, right? We've already had a lot going on in these communities, and folks are banding together, they're sticking together, they're saying we're going to get through this together, and they mean it. Not the little ads out there, but like really coming together and saying, you know what, if I'm going to get food support from you, then I'm going to give you my time. If I'm going to do this, I'm going to do that. And we really are in this together. And so there's an amazing, I think, silver lining in all of this, is that it shows the strength and the resilience of the communities we stand alongside. So again, thank you for including Martha's Table. Thank you for having us. Really appreciate it.
Well, before I go to Dion, I have a follow-up question for you, Kim. So this is remarkable, what you've been able to discover about solidarity in the community. Do you think this is going to persist beyond the pandemic, and how do we sustain that?
I think it can persist. I think how it would persist will be in the rebirth and the growth of what's going to come out of the pandemic, meaning that we all know we're not going back to whatever we had. And everyone talks about this new normal, which sounds kind of normal, but a little bit different. I think if we actually are bold and innovative and use this as a time, others have heard me say this, to leapfrog and get to the place that we're trying to get to, I think that's how it persists. I think that if we build new systems and new approaches and figure out ways to actually innovate in this time, that is how the bonding and the solidarity will continue, because then people will be in something moving together versus, okay, now we just revert back into, some semblance of what we had. So I think it can happen. I'm hopeful it will happen. And I know that we're going to do everything that we can to try to be a part of that innovation and that moving forward.
Okay, and one more thing you didn't talk about. I want people to appreciate the scale of the pivot you made. So before the pandemic, how many families were you feeding, and how many are you feeding now?
Yeah, I didn't talk about the pivot. So one of the things I mentioned is, like some of our sites and things moved, but we also changed our entire approach. So our markets were markets where people actually came and shopped, right? Well, you can't come and shop in COVID. So we turned our model into a bag and go. So we bag everything up, and then it's a contactless bag and go model. We were starting out at about 500 bags of groceries a day. We are over 2,000 bags of groceries a day. 2,000, usually running about 2,200 a day, Monday through Friday, and then on Saturdays from 300 to 500. And it has sustained. So we doubled from 500 to 1,000, then that doubled, and it has sat there for the past 4 months, and we don't see any decline coming up. And quite frankly, as people lose their jobs and their hours get cut, it could continue to go up. So the scale it's one of these things that people are like, oh my gosh. And I think that anytime that I'm forced to think about it, I'm like, no, I don't want to think about it. Like you just you focus on the mission, you focus on the people, and you just keep going, even when it means that you're ordering, 5 times more than you planned for, certainly didn't budget for. You need far more people power. You could get paralyzed and stuck in, oh, woe is me, and wow, oh my goodness. But we've decided that's not the mindset that we're in. This is what the community needs, and we're just going to keep responding and standing with them as best as we can. And with that, I got to stop talking because I want to hear from my dear friend Dion.
I know that's my fault. I wanted to get those follow-ups in. I think it's really important for people to understand the breadth of the services and the work you all are doing. So last but not least, Dion Bussey Reeder is the Executive Director for Far Southeast Family and Strengthening Collaborative. And Christy mentioned the piece I wrote in Forbes and interviewed all of you for that piece. And before you introduce yourself and give us your story, like what's impacted you the most during the pandemic, I have to tell people that you are the person who gave me the biggest aha moment, because I called you and I said, how is it when things like this happen, we keep forgetting about poor people? How do we keep forgetting to take care of poor people? And you said, it's not that we forget about them, we fail to plan for them. And I will never forget that because it's really true. So with that, tell us a bit about your organization and your impactful story from the pandemic that you think the health systems group should hear.
So I guess I should start off by saying, first of all, I thank all of you guys for just being who you are, Lisa, for the work that you're doing, the partnership that we developed. I literally remember last summer seeing you at an event. We were actually at an event and we stopped in the middle of Morris Street and you said, Dion, we got to get together. And we had no idea at that moment. And so now the relationship and how it will grow. But I definitely want to thank my colleagues for the work that they're doing. And I want to start off actually with the second part of the question. Personally, how it's impacted me, I've had to learn how to be flexible. As you see me sitting inside of a van, trying to have a panel discussion, getting all of these gadgets to work at the same time so I can have internet access. So that's the other part of this, is learning how to be flexible and respond to the need immediately. I think that's the piece of this that we have prepared ourselves to be able to do. And that's not something that occurred as a result of the pandemic. And that's where you were when I said we don't plan for the poor. So I'll start off by saying first, the Far Southeast Collaborative has been an organization in Ward 8 for over 20 years, working with families to sustain them beyond the child welfare system. And what does that mean? Some people say, well, Dion, what does that sound like? That doesn't mean anything to me. That means that years ago, when we realized that children were being neglected and abused, one of the things we recognized that it wasn't that there was no physical or emotional abuse, but the biggest issue in Ward 8 with the families that we served was poverty. Families were unable to take care of their children. So the basis of our work started as a child welfare agency connected to the child welfare agency to provide social services to families in Ward 8 to prevent child abuse and neglect. That's how we started. But thanks to the founders of the organization and the flexibility we had 20 something years ago, we recognized that in order to move families in Ward 8 out of poverty, we had to focus our attention on economics. So really, from that moment until now, we focus our attention from child welfare work to looking at how do we wrap ourselves around the entire community and provide services and partner with organizations like my colleagues on this line and figure out collectively, how do we deal with 50 years of systemic poverty? We don't talk about it a lot, and I'm the one that I'll toot the horn because I'm a fourth generation Washingtonian and I can say it. We pushed poverty east of the Anacostia River. And by doing so, what we created was systems that people felt that that was as far as they could go. And what we've done in this pandemic, as crazy as it sounds, developed, again, hope. I'm excited to be a part of this organization with Kim and Thrive, because this is instilling hope for families to be able to come out of a poverty-stricken situation and move to a level of sustainability like all of us on this line. I tell people all the time, we all want the same things. Because I'm actually living in a challenging community, and I have some real social ills, struggling with some mental health, that sounds exactly like my Reeder family. That's no different than what we deal with on each and every day. We just learned how to deal with it differently and cope differently. So for me, when I look at that thread and I look at the work that we're doing, and we're in several different spaces, we actually have recognized that the root cause of a lot of our issues, and I push my team in this direction. I'm not saying money is the reason, money is the cause or the solution to all of our problems. That's not what I'm saying. What I'm saying is that when you change economics, when you change education, you're opening up opportunities. And what this group is doing in this healthcare situation, because one of the public health issues that we're having in Ward 8 is really we're not able to meet the needs of the people because of the public health issues that we're having. As you know, Lisa, you work with the seniors that we have at our Senior Wellness Center. We have some of the highest rates of obesity, diabetes. I buried both of my parents, one to health, one to a heart disorder, and the other one to diabetes. We see that systemically in Ward 8. We see the effects of that. We see the poor nutrition. We see the fact that we have one grocery store. This was pre-COVID. One grocery store to serve 75,000 people. And then the question is, why is it that our families are going to the corner store or going to the ice cream trucks to get food to sustain themselves? Maybe it's because oodles and noodles cost $1 a pack. And if I have $10 and I have to feed 5 babies, I want my babies to be fed. So our issues are a little bit different. And the approach that we have to take, we have to deal with the actual, if we want to see change, and if you want to do anything systemically different, you have to deal with the root cause. So for us, those root causes are the health factors that we're talking about today. Those root causes are the fact that we have poor housing affordability for our families. You can't make $40,000 in the District of Columbia with 3 children and be able to afford to take care of yourself. And as soon as you get an opportunity, unfortunately, the system that we actually live within, it takes away your Medicaid, it takes away all of those things that will support you being able to sustain yourself. So what we do at the collaborative, we coach families to success. If that means connecting them to Martha's Table so they can afford adequate childcare, then that's what we'll do. If that means connecting them to another organization so we can ensure that we can work with them around mental health, then that's what we do. If it means that we need to make sure that you understand parenting, you're not parenting bad, but we want to show you how to parent differently. That's what we call the strength-based approach. We empower the residents that we serve to be the leaders of their own decisions. I truly believe when people have options, they perform better. And that's the movement of the collaborative that I'm pushing. I want our families to be able to sustain themselves in the United States of America. I know that sounds strange, right? Everyone is not going to be able to stay in Washington, D.C., because I want people to actually have life to their years. And if that means I have to move out of this situation so that I can add that, I want you to have tools to be successful for you and your family anywhere you go. So with that said, that's the way we do our work. The Far Southeast Collaborative is situated to ensure that the families in Ward 8 are connected to the right resources so they can thrive, that their children are safe, that we are diminishing and decreasing child abuse and neglect, that we're dealing with the social issues. And the other part of our work is that we work to build capacities of other organizations to do this work successfully. We have a robust subcontracting program. The majority of the resources, I'll tell you, 92% of the resources that come inside of the Far Southeast Collaborative goes directly out to our community. We have an employment of about 69 employees, but on top of that, I have at least 35 subcontractors that more than half of the resources that we receive go directly to those smaller organizations to build their capacity to take care of their own community. Many of my subcontractors actually live in Ward 8, was raised in Ward 8, or perform all of their services in Ward 8. We want to build a community that can take care of themselves. The other part of that that's critically important is the introduction to those philanthropists and those foundations. This is now the time. COVID has shown us that people do care. People would like to see all of the tides rise together. That's the true statement. I tell Kim all the time, the rainbow for me in the middle of COVID was Thrive. For me to be able to have families connected to an opportunity to have $5,500. We have one young lady Right now, she's working towards using those resources to purchase a home for her family. That's building generational wealth. She's going to sustain herself in a way that's going to move her beyond her current circumstances. So that's the work we're doing. That's our connection. And I, like my colleagues, can talk about this for hours, so I'm going to be quiet.
Thank you so much. But you all are raising a really important issue that I think warrants some discussion right now, because it's linked to what each of you have touched on, and that is this link between financial insecurity and health. I think we don't take the time to think enough about how living in poverty or living in an economically stressed situation leads to deterioration of physical and mental health. How are you seeing this play out during the pandemic? And anybody can answer.
Well, I guess I'll start and just say that, my background is education and workforce development, and I have long believed that the center of everything is economics. There's a reason that your zip code determines your educational level, your financial status, your health outcomes, your affiliations with the justice system, your environment, everything. It's all linked to money, right? So as Dion was talking about too, it's like, we've got to get to like root cause issues. And when you look at what's happening in the pandemic, like the folks who were well off are still well off, and they're actually becoming more well off. And they're annoyed by COVID because they're in their second home somewhere else, not able to participate in their regular life. Okay. Meanwhile, those who don't have money are in a 1-bedroom or 2-bedroom apartment, 600 square feet with 5 people, where their kids can't go out and play. Right. So you have one, if you look at IG, you've got folks who are like at their pool at the same time. Like
IG is that Instagram?
But yeah, Instagram. Like, you've got folks who are like real upset about the fact that, they can't get their favorite restaurant doesn't deliver to where your second home is. And then you have other people who, their kids can't even go out and play. It's not even an option. So then you have 5 people in this 600 square feet who now are all having to educate their kids at home. So now they're there, all day. Like being all day with a kid, I think has to be stressful in general. This is why I love teachers, right? But like you're there with your significant other, with kids, you have to now be a teacher. So then you have stress. So what we're seeing is a ton of mental and emotional stressors playing out. And you can see it in things like domestic violence. Numbers are shooting up. Violent offenses are shooting up. And so again, it really does go back to money. You don't see that happening in certain zip codes. You see annoyance and frustration, and I can't wait till this is over. In other zip codes, you see people ready to throw somebody out of a window because they don't even have the room to graze to be annoyed. Like we can't even get to annoyance. And so, I mean, that's what we see, and we're trying to provide as much as we can in terms of outlets, and not just, like when now do folks even have an opportunity to be with their friends, right? Like as an adult with their friends, having an adult conversation, being able to, like, these things are actually needed in society. And so again, certain zip codes can do that. They're in pods. They've identified their other friends and they're in a pod. And so they can still manufacture everything that's needed. And in certain zip codes, again, they can't. And it's directly linked to money.
Christy, do you have anything you want to add to that?
No, Kim, yes. And we, unlike Kim and Dia, we work with individuals and not families. So we're working with folks who are living on the street directly, usually with zero income, right? Try to live on zero income. And then even if they get income, the average income is Social Security disability. So forget affordable housing and living at 60% or 30% of AMI. People are living about $10 a day after rent is paid once they move in to cover food, clothing, medicine, co-pays, all that. And so the economic piece of it is we see that at every step of the way. I mean, we had a couple that we were working with here during COVID who they're on the street together, they're married, they've been homeless together for a few years. There's not a good shelter option for couples that they could access. They had an opportunity to get an apartment. That turns out the wife had an $1,800 back bill for a utility bill. So the apartment building wouldn't move her in, right? And she doesn't have the social network. And I think, both Deanna and Kim were talking about this in terms of the social network, the intergenerational wealth, to turn to someone where in that situation, I could turn to a family member and say, hey, can I borrow this money? She didn't have that, right? And so her health and his health impacted even longer by that just inability to pay the thing to get into housing that she's guaranteed, right? So we see it every step of the way. And I think the other piece is like, and maybe we'll talk about this around health and economics too. And another big piece of it is like the social isolation. And Kim is saying this, this is so real, the isolation, whether you're an adult with lots of kids and you need some adult time, or in this situation that we're working with people who are so isolated to begin with because of their mental health challenges, their lack of social network. And so, and even the work that we do is very intense. It's in people's homes to support them, to help them create social networks, and let's get you to church and help you feel comfortable there and find a faith community or whatever is important. But with COVID, that has been so incredibly challenging. And we know social isolation is actually one of the biggest impactors on people's health, right? And so just add on what was already a socially isolating situation for some people, or seniors, et cetera. COVID has so we've had to get really creative, as others are doing, and how do you get people connected? We also never closed our doors, and so that people who really still even need that connection still can come in a safe way and to work on those issues. But economics is the center of it, and I love that you give people cash. That's empowering people to say, you choose, you know what you need.
That's right.
You know what you need. We're not going to fix it for you. So yes, thank you for doing that.
So
that's a lot less paternalistic approach. I think some of the ways we approach these problems tend to be, we know better than you, and not relying on people's experience to dictate what they need. So,
I mean, that's how our housing model came about. Housing First is that because our entire public housing system and mental health system thought they knew best for people and said, you need to be clean and sober first before you could succeed in housing. You need to learn how to cook before. No, people are surviving on the street. People know, if they would say that they want a place to live, we consider them housing ready, right? Listening to people, and that doesn't mean that you're on your own. That's walking side by side.
Would be so offended if you told them how to spend their money.
Yes.
They would never expect
how to spend your
to say, we're going to spend your money how we think you should spend it.
That's right. But when you are poor, that's right. Your life, when you're poor and you have a disability or anything, but when you're poor, your life is in our microscope, and you're held to a different standard than others in our community who are not poor and who have means, right? Like that's a whole conversation. I'm sure we could go on for hours, but we hold people under a different standard when they're receiving benefits that we feel like they need to earn sometimes as a society, and that's just wrong.
Let me give Deanna the last word on this one.
Yeah, I was just going to jump in. I mean, I know I'm with a group of, and this is our passion. That's why I get it. I know how we're talking about this. And I'm hoping, Lisa, that you pull us together again to further have this discussion in another setting. But I wanted to just jump in really quickly with Christy. It was almost like right where I wanted to be. What she stated was so clear. And I wanted to move just a little bit into the digital divide. Could you imagine what Christy is dealing with homeless families, with no access to internet with children? I mean, we jump into this place, and that's what I was talking about, Lisa, when I said we don't plan for the poor, because right now we've been extremely innovative. And if it was not for this opportunity, the ideas and the innovation that we've been talking about, it would have been pushed aside. You know what happened? It was a desperate time, and we were actually able to provide an opportunity together. Because what Christy's doing, what Kim is doing, Lisa, what we're doing together at the collaborative, This is exactly what we needed to show the world could happen so that we can show everybody, regardless of where you are, this pandemic, and I like to call it a plandemic because I believe it was planned. This pandemic actually was going to hit you. I don't care where you are. The difference is how you come out of it. And that's the piece for us that we don't talk about a lot because of the economics. I have friends that are able to position themselves. They have the kind of careers that their jobs are giving them $1,000 a month to help support the education process for their children, which means they can hire someone to come into their homes and teach their children and don't have to worry about being online with them all day. Now, in comparison to the families we serve, I'm going to take a page out of Christy's book. Most of our families that we serve who actually do have housing, we're talking about the minimum are 3 children, minimum, on my caseload. Normally it's 5 in a 1-bedroom apartment. And most of them are all in primary education. Most of the times, the mother or the father, because I want to make sure we acknowledge that we do have fathers in our homes east of the Anacostia River, have not completed the grade levels where their children are. Even those who have not done the math in these that was being done in the elementary schools in so long. So not only now do we have a digital divide, an educational divide, now we're talking about a mental health breakdown. One experience, I'm gonna give you guys one example and I'm gonna be quiet because we have to pull this home. I went to deliver some gift cards to a family who was actually on one of our caseloads. The mother was sitting outside. I didn't know that was the mother. Went inside the unit, knocked on the door. The kid said, "Oh, you didn't see our mom? She's outside." I went back outside. She said, "Oh, I'm sorry, I'm here." I said, "I'm Dion, I'm here." She said, "I just needed a break." She said, "I'm sitting in my car because I just needed 5 minutes. I needed 5 minutes to get away from this whole thing." We connected her to our mental health therapy. As a result of that one young lady, we started doing what they call it art and paint or chat. It's similar to the chat and paint. But we delivered all of everything you would need to do your art to our families' homes. We started a whole virtual learning process. We delivered laptops, hotspots. I bought cell phones if I had to, so they can have a hotspot in their homes, whatever we had to do, so they can connect to someone outside of that house that wasn't a 3-year-old, 5-year-old, or 12-year-old telling them what to do. So that for that family opened up an outlet for the mother to get mental health services and also for us to decrease a potential child abuse neglect case. That's how real this is. And I don't think we're understanding the effects that this COVID situation is having on not just poverty, because this young lady works every day, but on the communities that are challenged. And I think we have to be smart about how we come out of this. And if we're going to be in this longer, these kind of relationships and these networks, we have to do more of this so that we are connecting our families to the right resources so they can survive.
Yeah. So we definitely will talk about the digital divide, but first I want to have you all respond, each of you respond to something. And that is, we're talking a lot, what we're talking about with you all is linked to social determinants of health. And this is a really prevalent topic of discussion within healthcare and beyond. And GW, the School of Public Health, thanks to Bob Dayton, I don't know if you all know him, but the School of Public Health, or the medical school, is one of the few medical schools in the country that actually integrates principles around social determinants of health into medical school, the medical school curriculum. But I've had students ask me or even say things to the effect that, well, I'm going to be a radiologist. I don't really need to learn this, or I'm going to be a pathologist, or my chosen career doesn't have anything to do with this. And I suspect there are leaders throughout health systems, people who work in other aspects of healthcare they might be listening to you and thinking, this is not something I can deal with. Like, this is not my role. It's not my responsibility to deal with these social determinants or these issues you all are raising around poverty, around food access, housing, and so on. So knowing that this is a health-related audience, what is your advice or suggestions for how the health system and those of us who are working in healthcare, whether we are doctors or educators, administrators, leaders of any kind, what advice do you have for us about how we can improve health outcomes while also focusing on these really important issues you're raising? And I'll start with Dion. Well, Dion, you just talked. I'll give you a break. So why don't we start with you, Kim, then Christy, and then you want to go first?
Yeah, I had a quick answer actually. I think my colleagues
Okay.
they probably expound a little further than I can. I know for me the most immediate need, and this is what we deal with the most, the way that the actual, I'll say those individuals who are working in the healthcare field, how you can actually help us the most is really we have to figure out, like we have figured out how to do community-based child welfare work. We have to figure out, Lisa, is more in line with what you've done with us. How do we pull you all into our settings? We have to meet our families where they are. In my case, let me say that our families are not comfortable with trusting the healthcare system. And mainly that's because we don't have a very robust healthcare system east of the Anacostia River. Their experiences with the healthcare system is not always pleasant. And as a result of that, they see that just like many people see law enforcement, but they don't see that as a partner. And they also don't see mental health as a way of growing. So if we can figure out how we can bring more of our healthcare providers closer into our communities of challenge, work inside of the organizations like Far Southeast, like our homeless population with Christy, like the Martha's Table, find spaces in our space so we can actually pull you into the community, make you a trusted partner, see that your needs, what you're saying. I mean, Lisa, the things you say to even me about my own health, eating too much sodium, things that I've been doing all my life. It changes when you have a relationship. So connecting with community-based organizations like ours, it creates a relationship that normally coming from George Washington, Georgetown, or even UDC, if you're not in that community and in that space, people do not trust you. So the way I see our partnership and the way I see us working with the public health officials and all of those of you all who are in healthcare, let's partner and bring you into our space. Come on over to East of the River. Join us like Lisa do and get inside these spaces, make yourself a common factor, a common figure, so health is a prominent conversation and we don't see our primary healthcare provider like the emergency room. That's it for me.
And does it matter what race or ethnicity you are?
Can I be me, Lisa? You want me to be Dion Reader? Dion, okay. So actually, we are more accepting and we're more trusting of people who don't look like us, unfortunately, sometimes. We have a different sense of, we believe sometimes, and I'm saying this and I'm jumping myself out there, Lord, but I believe in my cases, what I've seen more often than not is that we trust differently when we see different. And it opens up a relationship. And what it can do for us, it'll bridge the gap between this whole racial issue that we're having. People do not need to assume that only certain people live east of the Anacostia River and certain people live west of the Anacostia River. We need to do something right now to change that. And through the healthcare model, I believe will be a very safe place because we all want to be healthy.
Yeah, so I mean, I would just say I think Dion hit on a number of different things, and I want to harp on the trust point. So one, Dr. Fitzpatrick, you talked about, I'm in radiology, I don't do this, I want to do this. I just want to talk about concentric circles. Everything actually has an overlapping point. So when you talk about the social determinants of health, the whole purpose of that is that they're all linked. Like you can't yank out transportation and think that that doesn't affect health. You can't yank out employment and don't think that it affects health. A prime example is if you're a shift worker or you're hourly and you can't take off, you can't get preventative care, right? Or at least you think you can't get preventative care, or you have to give up a cost to do that, so on and so forth. So I think for those, we have to understand all the concentric circles and that everything is sitting in a bucket somewhere around and think about the like Olympic links. But I want to talk about also like other things that are, inextricably linked. And, Dion talked about trust. And trust is one of these things that is incredibly, it links back to systemic issues. And there are a lot of things, particularly racially, that have, whether you believe intentionally or not, and in most cases it actually has been intentional, are to create certain communities to distrust systems. So Dion talked about health. We could talk about voting. We could talk about filling out the census. And again, all these things go together, right? So if I don't want to, if I'm scared to fill out the census because I think that I'm going to get deported, or I think that that means that the government's going to come do something to me. But remember, that's linked to the money that then actually comes into programs for things like health, right? And then I don't want to vote because I don't either think my vote counts or I think, again, something bad might happen to me. But that's also linked to these other things. Like everything is just so inextricably linked. And so when I think about health, I would ask the colleagues and the students who are on the phone to just know that you're not in healthcare. You're in the business of people. And people do and experience a number of things. And that's jobs, and that's health, and that's empowerment, and that's everything, right? So, like, I think we have to stop thinking in one of the links because each link is linked to other links. And because of that, you're just a part of the overall system of links. And if you start looking at it differently, then I think that future radiologist understands why maybe they don't only need to know about the social determinants, but maybe they really want to get well versed in economic policy. You know what I mean? Like, so that's just what I would offer. And I think that if we all approach things from the fact or the mindset that we're in the business of people, then we can instill trust. And when you have trust, you start knocking down all of the other pieces of the system that have been built to reinforce distrust.
Beautifully said, both of you. I mean, yes, all around. And that trust piece, I can't say enough. Just from our space on the homeless services side, and also Pathways, we really also specialize in working with people with serious mental illness like schizophrenia, bipolar disorder, complex addiction and substance use challenges. People have a very good reasons not to trust the healthcare system. And it's a privilege that people let us into their lives and that they open up to us in the first place. And it is about that relationship. And I will say, that I rely on our healthcare partners to work with us oftentimes to make reparative experiences for people that can then lead to other things. And what I mean very quickly, I know we're running out of time by that, is that there's so much stigma around mental illness, right? And so a lot of the people that we work with on the street and then still into housing don't want to share or get treatment for a serious mental illness because there's so much stigma behind it. But what's normal is healthcare. Everybody's foot hurts, right? So going to a podiatrist could be that first step of regaining trust for the healthcare system, which could lead to a conversation to say, hey, and we see this all the time. We had a gentleman dying on the street, actively bleeding out internally, who would not talk to a healthcare provider. Anyways, a long story short, it took that window of him literally coming to our office to get a shower. He felt so good. He had bed bugs, he had lice. Right? The hospital would just reject someone and say, oh, sorry, or the clinics don't want to work with folks. We brought him into our office, cared about him, loved him, and love is a real word in this space. We like to avoid it. Treated him with respect. That shower led to him feeling so good. He agreed to get his blood work done from our nurse, which led him to say, yeah, I'll see the psychiatrist today, right? It's those little things, those little interventions, but ultimately it saved his life because he finally trusted us, our nurse and our doctor, enough to say, I will actually go into the hospital. So you are that first point of interaction for a lot of people. There's real reasons why they don't go that Kim and I talked about, right? And it's not because they don't care about their health. It's because if you have to figure out where I'm going to eat today, going for a preventative follow-up care with a nephrologist or radiologist, it's going to have to take a back seat. It just is.
Excellent. Okay, well, thank you all so much. I'm going to ask you one more question. We're ending at 1, so I do want to leave a little bit of time in case there are questions. I know we have at least one. So now, yes, let's talk about the digital divide. I mean, it's sort of the elephant in the room these days. Everything's gone virtual. It drives me crazy, but it's our reality right now. You know, people say this is the way it'll be in the future, and I push back against that a little bit. But in healthcare, this is a big deal. So someone was mentioning how before it was no, 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 you can't do that. These are all the restrictive reasons why you can't do that. And all of a sudden, telemedicine in particular is at the forefront. It's become an imperative. I don't necessarily want to talk about that. What I want to talk about is this. Everybody's talking about the digital divide. And my perspective on this, because I'm doing telemedicine right now, and some of these telemedicine visits have actually I've converted them to home visits because I didn't feel comfortable just talking on the phone or doing a video chat. But for me, the issue around the digital divide in healthcare, because 90%, 95% of the people we're interacting with, and I knew this just from the work we do in the community, most everyone owns a smartphone, even your clients, Christy, and you can talk about this, right? So for healthcare, I think that the conversation about the digital divide is different than when you're talking about education. Because I think it's a foregone conclusion that there is definitely a digital divide, a crevasse between those who have and those who don't. But in healthcare, if all you need really is a smartphone to make the connection, do we really have a digital divide in healthcare? And what are your observations around access to technology in the populations you're serving? So I know that's a bit of a loaded question, but I think we make a lot of assumptions when we hear these conversations about digital divide. Healthcare is not like education. So what are your thoughts? Kim, do you want to start?
Sure. I think, and I'll be brief. We have not found an issue with devices. What we're finding now is an issue with bandwidth. So we've surveyed umpteen times, and to your point, families have smartphones, families have laptops, families have gizmos galore. It's now we're all in the same place online at the same time, streaming and learning and loving and whatever. And so that now is becoming an issue. And so, like Dion mentioned, working on trying to hotspot, boost up, give people more bandwidth, but we really haven't seen that. And even our guests on McKenna's who are facing housing instability, most of them whip out phones. Whether or not they have a data package is a different question. But I've received emails from guests from McKenna's from their phones. Like, I'm gonna email you right now, and they do. So it doesn't seem to be a device issue with our families and the folks we're touching. Few and far between do we hear that, and we support that. But we're running into now bandwidth, speed issues.
Are you able to video chat with people?
Yeah, I mean, our virtual learning is via video. We do virtual circle times. We do virtual family visits in folks' homes, and folks are walking around. We're trying to simulate everything that we would normally do in person. But again, we do run into the whole, like, somebody then freezes. Well, we're frozen. But again, for us, it's what we're mostly seeing is that bandwidth data issue, not necessarily a device issue.
If I may, I think I was starting a conversation about the whole digital divide piece. I think for us at Far Southeast, it was a little bit more because of the amount of work we have to do with so many various sizes of families. And we initially, and Lisa, early on, we talked about this before the school year was over, how instantly we had to identify resources outside of our network of resources to really meet this need. It wasn't something that was contractually in our program. So unlike him, we did have families with cell phones and the like, but the internet access, cell phones provide you cell phone coverage, but that's not internet in your homes. So many of our families did not have internet in their homes, especially many of our grandparents who were raising their grandchildren. So for us, it became something that then once we had given them the access to the internet, it was their ability to use it. So all of those things kind of came into play. Kids know how to do what kids know how to do. I tell people my granddaughter teaches me things on my phone and she's 7, right? But she's had exposure. She's had an iPad since she was 1. But the point is she's had 7 years of technology, even within her own environment. Many of our families, their technology is the cell phone, is this. And that does not yield to the level of access we need in the world we're living in today. So it's caused for me a major awakening around the digital divide, something that I've taken for granted since I've been able to use it. So again, it's about that. It's about economics. If you can afford more bandwidth, as Kim said, then you'll have it. If you can afford to increase your data package, then you'll pay $100 a month for a cell phone with the maximum. Many of our families can't do that. And you definitely can't do it for multiple children, multiple devices in a home environment, again, in one bedroom. So for us, it's a larger conversation, and it affects our family stability and their mental health. It creates anxiety that you would not believe, even trying to access opportunities for them to get new employment, which is a whole nother conversation. So yeah, it's a piece that we have to do something around. And I think the city we need to be more committed as a whole community. And I'm not just talking about the providers.
Have you, Dion, have you had any discussions or heard any of your clients talking about this specific to healthcare? Are they having difficulty accessing providers using technology, or what are some of the challenges you're hearing around tech and health?
They are, many of them are struggling, even with, like you said, the telemedicine. We had a couple of people before we had access to the COVID testing site then on Martin Luther King Avenue. Many of our families were telling my staff that they think they had COVID, but they couldn't get into the doctors and they didn't know what to do. And when they would try to reach out, they had this telemedicine and they didn't know how to access it because their phones we went through that whole process. So, again, I think it's about sometimes it's about your ability to understand I do telemedicine with my therapist. You guys know me, I'm transparent. It took me almost 2 weeks before we can get this thing right with she and I. And I consider myself to be computer savvy, technology savvy. So I'm just saying we have to be very mindful our expectations of people when we jump ourselves right into something new. And when you're dealing with the vulnerable population, it takes time because there are so many other stressors that they're focused on.
Yeah, and if I could just really quickly say, our families have absolutely no intention at this point in engaging in like telemedicine. I mean, again, it's one thing to have distrust in healthcare, but like if you think we're gonna put that online and I mean that
Say more. Why?
Yes. It's a trust issue. Again, we're
Okay.
back to trust. Like, I mean, the notion of having like something emailed to you, the notion of having a conversation over open lines, about health and stuff, and even just like the discomfort of not being in a place. Like you have to think of how we're conditioned to certain things, right? Like my grandmother will not do mobile banking. Like she has to go to the bank to conduct financial business. So when you think of like healthcare, a lot of times, particularly physical healthcare, people really believe that I am supposed to be in a place with my doctor in a confined space and having like that kind of open conversation. This whole, I'm gonna just video chat, like right now, I'm not gonna say, look, hey, Dr. Fitzpatrick, I got asthma, I got some pounds I gotta lose. You know, I mean, it's just we're not there yet with a lot of
Okay.
communities that we stand by.
All right, Christy, I have to let you
Yes.
have the last word on this one. Telemedicine.
Just very
or
quickly,
digital
yes. We did some internal surveying of folks in our housing. Just for context, like 65% of the people that we talked to are over 55. The piece around the age, culture, all that is so huge. Most of the folks we work with do have cell phones. 75% have smartphones because they get them free, the Lifeline phones. But people have problems keeping them charged. They don't know how to use them. And very quickly, we went from people having smartphones and just needing to know how to make a call to needing to understand how to download things, to interface. It doesn't have so, and that takes a lot of one-on-one training. And as Deanna was saying, over and over and over again. So our staff still meets with people in their homes, but with COVID, you're trying to minimize the length of time in someone's home. So the teaching piece is huge. 75% of the people we work with say they would love a laptop, but 70% have no internet, right? So while they have a device, understanding the technology enough to be able to interface this way is a monstrous barrier. But people have the desire to learn. A lot of the folks we work with have the desire. I mean, so we have to make it easy and very quickly and around those innovations. Like really the first thing we did was our psychiatrist, who himself is in his 70s, we set up a technology, a computer with a video camera in our office. To your point, Ken, where people feel comfortable coming into the office, even if they have a smartphone and could do video chat, they come in, they sit in, we thank you very much, we welcome them, that we get it set up so that they can connect. So that's been kind of a workaround that we do that we can control internally, but it's even harder with healthcare providers where it's about scheduling and keeping the schedule. And so while people who have more resources economically and emotionally and internally might have better access, like so many people are doing online therapy now, which is great. It's awesome. But for a lot of people, that just doesn't work for all the reasons we've talked about. So I think in the future and around the innovation, it cannot take the place of other than face-to-face. It's hard to do a diagnostic sometimes, like really assess someone's needs. So it needs in the future, it's got to be a hybrid. And actually, just a very quick plug, we're very thrilled. We have a longstanding relationship with GW's psychiatric residency program. And it's really critical to take, psychiatrists, the physical health doctors into people's homes, to your point, Dr. Fitzpatrick, for the home visits. So it's got to be all of it moving forward. We can't ditch one way and say it's all tech in the future, or we will leave a whole host of people without access to healthcare because we say they should figure it out. I think you're
Lisa,
muted.
Sorry. We have 3 minutes left. I've been monitoring the chat. And one of the questions was already answered in the discussion. There was one other question about telemedicine and trust. I think you answered this, but I will, I think I'll just ask. So this trust issue around telemedicine, do you think it makes a difference if the person trusts the provider versus thinking about it as a health system? Does it matter? Or do you think there's still an issue there? Yeah.
I said yes. I think it goes back to what we were talking about, relationships. I think, and what we fail to realize is we sometimes, and this is no offense, sometimes we talk about people as if they're estranged to us, that they're not the same. Like we're not all people. We all want to have relationships. I have Crohn's disease, so I just wouldn't go to any gastrologist. I've built a relationship with my doctor for over 10 years now. So now that if I have an illness, if something happens to him, if he doesn't give me a referral, I'm not going to go. It's the same concept with the residents that we serve. They want to have a relationship with someone. So it's not that they're afraid so much of telemedicine. It goes back to Kim's point. It's not something that they're familiar with. And once we build in a relationship, which I'm so happy, let me just say this in terms of I know we're going to be closing. Thank you, Lisa. because we need to be connected to GW. We need to do more of this. We need to have you all in our environment, not just GW, but many of our healthcare providers. We need to be in this space together so we can build the relationship like we built with the residents. So for me, it's around the trust. Is like the same thing any of us would feel. They're not afraid of telemedicine. It's not something that they're familiar with. They're not familiar with having a reliable healthcare system in their area. We don't have one. We don't. So we have to look at everything systemically and understand, if I'm familiar with you, then I can have a conversation with you. And if you tell me next week, hey, we got to get online and see each other, I can't see you face to face, well, I already know you, so I'm willing to do it. So I just want to, yeah, that's what it is for me.
Yeah, so we're at time, so I will give each of you 30 seconds to, if you have a call to action for the healthcare folks at GW, please do, but also tell people how they can get involved with your organization or how to reach you. So start with you, Christy, then Kim, then Dion.
Sorry, I was just typing my information into the chat. I'll stick the information in the chat about how you can get connected to the healthcare industry. I ask that many of you, please, I beg of you actually, to stay connected to community medicine. We need docs who are not just in hospitals, but also we need physicians and healthcare professionals who are working in community medicine in the communities that we're talking about here, and not just, private practice, et cetera, which is great. But we really need you connected to the communities that we're all serving. They deserve you.
And I just want to thank my colleagues on the panel, and thanks GW and Dr. Fitzpatrick. Martha's Table, of course, I've already put my information in. My call to action is, you're not just a med student, you're a person, and the people that you're going to be working with are people. And so I always just ask people to learn more, do more, and love more. The more you can get out of your silo and get into just the world. And I know that must be hard in med school, but come volunteer here one day and it will put into perspective anything that you're studying. So thank you for your time, and thank you for having us.
And why did you let me go after Kim? I'm not going to be able to have a great statement like love more, do more. Like, I'm not that cool with that. So
you're far more eloquent than me, Dion. Come on.
I echo the comments of my colleagues, Christy, Kim, Dr. Fitzpatrick. Once again, you're dynamic. Thank you for bringing life to our ward. You're a resident in Ward 8, and you understand our dynamics and the work that we're doing there. So thank you for merging us with GW. I, like Kim and Christy, come out. We need you, GW. We need your expertise, and we need you to be people. Remind yourself that you're just a person. And I, like Kim, I want to say, like Christy, understand that we need people who love people, that really want to be in the people space, loving on each other. We don't need you to be compassionate about us. We already got that covered, but we need you to we need you to understand that the residents and the communities that we serve are just people, and we want what's best for them, and we're asking you to make that happen. Again, I open up my organization to come in and volunteer. We have several sites that you can actually spend some time there and figure out a way that we can partner together so we can really put an end to some of the social ills that's happening in the community that deserves more and deserves to be loved on. So thank you, guys. And thank you so much, Lisa. This means the world to me. Thank you for involving us.
Sure, and thank you guys so much for your participation. I'm sure the people who are listening at least took away one morsel, heard something new today. So appreciate your support and your service, and I'll see you in the community. Or as I say on my videos, I'm Dr. Lisa, and I'll see you on the street.
Have a good one. Bye-bye.
Bye.
Yeah.
Okay, bye.